Hi everyone, this is Dr. Teresa. So in this lecture, we're going to go over the blood vessels. Okay, so the general anatomy of blood vessels is what we'll get into first. In this cross section, you can kind of see the layers. I don't think this is a crystal clear representation, but we'll go through it. I'll read down through the parts that you might be able to identify. So we can see capillaries. Within the artery, we see the layers of the artery, the tunica interna, the tunica media, and the tunica externa. And I think you can tell by the names where the layers of the arteries lie in relationship to one another. We can see a cross-section of a nerve and then a cross-section of a vein. So when we're discussing the vessels of the cardiovascular system, we need to understand that arteries carry blood away from the heart, veins carry blood back to the heart, and capillaries connect the smallest arteries to veins. So within that vessel wall, this is what we were talking about on that picture where we saw the layers of the vessel in and of itself. So we have the tunica interna or the tunica intima. This lines the blood vessel and is actually exposed to the blood. So this is the innermost layer of the vessel. The endothelium is simple squamous epithelium overlying the basement membrane. This will act as a selectively permeable barrier. It will secrete chemicals that can dilate or constrict the vessel. It normally repels blood cells and platelets unless the tissue around the vessel is inflamed. Then endothelial cells will produce cell adhesion molecules that induce leukocytes to adhere to the surface. This causes the leukocytes to congregate in the tissues where their defensive actions are needed. The tunica media, that middle layer, is really smooth muscle, collagen, and elastic tissue. It strengthens the vessels and prevents blood pressure from rupturing them. Vasomotion is changes in diameter of the blood vessel brought about by smooth muscle. The tunica externa, or the tunica adventitia, is the outermost layer of loose connective tissue. It often merges with that of neighboring blood vessels, nerves, or other organs. It anchors the vessels and provides passage for small nerves and lymphatic vessels. The vasa vasorum, the small vessels that supply blood to at least the outer half of the larger vessels. Blood from the lumen is thought to nourish the inner half of the vessel by diffusion. So these layers are going to need nourished as well in order to stay healthy and function at their optimum. So what this is demonstrating is that vasovasorum are vessels that are intended to supply the outermost portion of larger vessels because the diameter is going to be bigger. And the inside of the vessel itself, where the blood will run, what they're saying here is that we think at this point that the nourishment for those inner tissues comes directly from the blood by diffusion. So here's another example, another picture of the vessel wall. You can see large veins, medium veins, and venules. You can see conducting arteries, distributing arteries, and arterioles, as well as capillaries. Again, capillaries are the connection point between arteries and veins. And you can see their layers. You can see the basement membranes demonstrated on certain examples here. So let's talk about the arteries. Arteries are sometimes called resistance vessels because they have a relatively strong, resilient tissue structure that resists high blood pressure. Conducting arteries, these are elastic or large. are the aorta, the common carotid, the subclavian, the pulmonary trunk, and common iliac arteries. They have 2 layers of elastic lamina. These expand during systole, they recoil during diastole, which lessens fluctuations in blood pressure. Distributing arteries are muscular or medium arteries. These distribute blood to specific organs. These would include the brachial, femoral, renal, and splenic arteries. Smooth muscle layers constitute 3/4 of the wall thickness. Resistance arteries are small. These are arterioles, which are the smallest arteries, and they control the amount of blood to various organs. Meta-arterioles are short vessels that link arterioles to capillaries. The muscle cells form a precapillary sphincter at the entrance to the capillary. Constriction of these sphincters reduces or shuts off blood flow through their respective capillaries, and this diverts blood to other tissues. So here's an example of that, where we have the arterial, and then we have the capillary, the venule, and then the capillaries that are meeting in the middle. And then we have the meta-arterial, which is going to join into the capillary. We have the precapillary sphincters. You can't really see them super great on here, but the arrows are pointing to examples of those sphincters. So there are sensory structures in the walls of certain vessels that monitor the blood pressure and the chemistry, and this is so we can maintain that homeostatic balance as best we can. The functions, these transmit information to the brainstem, which then will in turn help regulate heart rate, vasomotion, and respiration. The carotid sinuses, they have what we call baroreceptors or pressure sensors. These are in the walls of the internal carotid artery. The function is that it monitors blood pressure and signals the brain. The response would be to alter the heart rate and the vessel diameter in accordance with the blood pressure. Carotid bodies are chemoreceptors that monitor the blood chemistry. These guys are in the common carotids. They signal the brainstem respiratory centers so that the resultant response would be to adjust the respiratory rate. This is so that we can help stabilize pH by altering the buffer system, increasing O2 intake and increasing CO2 output. We have aortic bodies, which are also chemoreceptors in the walls of the aortic arch. This will send signals to the brainstem respiratory centers in an attempt to also adjust the respiratory rate and change pH, CO2, and O2. So the chemoreceptors, you can understand by how it's demonstrated here what their function is in adjusting that pH. In this picture, it's just given us an example of a carotid body chemoreceptor and an aortic arch chemoreceptor. So when we go into the capillaries, the smaller vessels, nutrients, wastes, and hormones are exchanged between blood and tissue fluid at this level. Materials will pass through the walls of the vessels composed of endothelium and basal lamina. Absent or scarce in the tendons, ligaments, epithelia, cornea, and lens of the eye. There are 3 types that are categorized by permeability. This is the ease with which substances will pass through their walls: continuous, fenestrated, and sinusoid. So continuous capillaries are in most tissues. They're tight junctions between endothelial cells. They form continuous tube with intracellular clefts. Pericytes wrap around the capillaries. They contain the same contractile protein as muscle tissue and contract and regulate the blood flow. These will allow passage of small solutes like glucose. So here's an example of the continuous capillary. We can see the red blood cell floating through it. We can see the tight junction at the very bottom of the screen. We can see the endothelial cell to the right side of the picture. An intracellular cleft, we can see the layers of the basal lamina, and then we can see what we call that pericyte. Okay, so a fenestrated capillary. We find fenestrated capillaries in the kidneys and the small intestine. These require rapid absorption and filtration. Filtration pores or fenestrations are in these, giving it its name. Endothelial cells riddled with holes allow the passage of only small molecules. Sinusoids or discontinuous capillaries. We find these guys in liver, bone marrow, and spleen. Large fenestrations with blood-filled spaces. These allow large molecules or cells to enter the bloodstream, such as proteins like albumin, clotting factors, and blood cells. So here's an example of the fenestrated capillary. You can see on the slide prepared under the microscope, it has a non-fenestrated area of this, so the fenestrations don't have to be the entire way around it. But you can see the holes, again, designed for movement of particles, solutes and fluids and whatever else needs to move between there. Here's an example of the sinusoid in the liver. We can see the endothelial cells on the inner portion. We can see what's labeled as the sinusoid cavity, I would say. Okay, in this fold, we can see the liver cell or the hepatocytes that comprise this whole structure. We can see how the blood goes through that cavity or that space, which is the sinusoid. And then there are macrophages lined in there too. So in a capillary bed, or a capillary bed, is a network of organized capillaries. They're supplied by a single meta-arteriole. It's a thoroughfare channel, meta-arteriole that continues through the capillary bed to the venule. Precapillary sphincters control which beds are well perfused. So again, another picture of that capillary bed. When the sphincters open, the capillaries are well perfused with blood. They exchange nutrients for waste with the tissue fluid. When the sphincter closes, the blood bypasses the capillary, and then it will flow through the thoroughfare channel through a venule. 3/4 of the body's capillaries are shut down at a given time. So that's most of them. When the sphincters are closed, there's little to no blood flow that occurs. And this would be an example of skeletal muscle at rest. Interestingly, veins contain more blood than arteries. They have thinner walls, they are flaccid, and they have less muscular and elastic tissue. The veins actually collapse when they're empty and can expand easily. They have a steady blood flow. They begin after the capillary bed and they merge to form larger and larger veins. They're subjected to relatively low blood pressure, which remains at 10 millimeters of mercury with little fluctuation. So that 10, pretty constant in those veins. Okay, here's just a little chart that gives you an idea of total blood volume in a human. Where is it? 54% of it is hanging out in the veins, only about 5% in the capillaries, 11% in the arteries, 12% in the heart in and of itself, 18% in the pulmonary circuit. So the post-capillary venules, these are the smallest veins, and they're more porous than capillaries. They exchange fluid with surrounding tissue. They are made of that tunica interna with a few fibroblasts and no muscle fibers. Most leukocytes emigrate from the bloodstream through venule walls. Muscular venules, which are up to 1 millimeter in diameter, are made of 1 to 2 layers of smooth muscle and tunica externa. Medium veins, which are up to 10 millimeters in diameter, they're made of thin tunica media and thick tunica externa. They contain venous valves, and they're formed from tunica interna. Large veins, larger than 10 millimeters, are smooth muscle in all 3 tunics. They contain longitudinal bundles of smooth muscle, and they are the thickest in the tunica externa. These guys would include the vena cava, the pulmonary veins, the internal jugular veins, and the renal veins. So here's an example of your circulatory route. Simplest and most common route goes from the heart to the arteries, to the arterioles, to the capillaries, to the venules, to the veins. This passes through only one network of capillaries from the time it leaves the heart until the time it returns. The portal system, the blood flows through 2 consecutive capillary networks before returning to the heart. Between the hypothalamus and the anterior pituitary, in the kidneys, and between the intestines to the liver. So the portal system is where we're going to see 2 capillary beds doing some exchange of blood and nutrients. An anastomosis is a point where 2 blood vessels merge. Arteriovenous anastomosis, or a shunt, is where the artery flows directly into the vein by bypassing the capillaries. A venous anastomosis, one vein empties directly into another. Vein blockage is less serious than arterial blockage. Arterial anastomosis is when 2 arteries merge, provides collateral or alternative routes of blood supply to a tissue. This happens in the coronary circulation and around joints. Okay, so when we talk about blood flow is the amount of blood flowing through a tissue or blood vessel in a minute, and this is measured in milliliters per minute. Perfusion is the flow per given mass of tissue in a minute, so it's milliliters per minute per gram. Hemodynamics, that is the principle of blood flow based on pressure and resistance. The greater the pressure difference between 2 points, the greater the flow. The greater the resistance, the less the flow. So blood pressure is the force that blood exerts against a vessel wall. It's measured at the brachial artery of the arm using a sphygmomanometer. It's measured in 2 numbers, as we know. The systolic pressure is the peak arterial blood pressure taken during ventricular contraction. So this is labeled ventricular systole, or systole, however you choose to pronounce it. Diastolic pressure is the minimum arterial blood pressure taken during ventricular relaxation, or diastole, between the heartbeats. So systole is contraction and diastole is relaxation. So the normal value in the young adult is 120/75. And that actually is going to depend on resource a little bit, as usual. Check your resources. Actually, that may even be different per country, from what I understand. Hypertension is what we call high blood pressure. Chronic is resting BP of 140/90. It can weaken the small arteries and cause aneurysms. Hypotension is chronic low resting blood pressure. This is caused by blood loss, dehydration, and anemia. So pulse pressure, this is the difference between systolic and diastolic pressure. It's an important measure of stress exerted on small arteries by pressure surges generated by the heart. The mean arterial pressure, or the MAP, is the mean pressure one would obtain by taking measurements at several intervals throughout the cardiac cycle. Diastolic pressure is 1/3 of pulse pressure. I'm sorry, let me say that again. The diastolic pressure plus 1/3 of pulse pressure. The average blood pressure that most influences the risk level for edema is fainting or syncope, atherosclerosis, kidney failure, and aneurysm. Blood pressure is determined by cardiac output, blood volume, and peripheral resistance. Peripheral resistance is the opposition to flow the blood encounters in vessels away from the heart. Resistance hinges on 3 variables: blood viscosity, or its thickness, which can be contributed to by an RBC count and albumin concentration that elevate the viscosity the most. Decreased viscosity with anemia and hypoproteinemia will speed the flow, and increased viscosity with polycythemia and dehydration slow the flow. So the vessel length, the further the liquid travels through a tube, the more cumulative the friction it encounters. Pressure and flow decline with distance. The vessel radius, this is the most powerful influence over flow. Vasomotion is the change in the vessel radius. Vasoconstriction, by muscular effort that results in smooth muscle contraction. Vasodilation is by relaxation of the smooth muscle. Laminar flow flows in layers, faster in the center. So from the aorta to the capillaries, blood velocity, or the speed, decreases for 3 reasons. It's a greater distance, the more friction reduces the speed. The smaller the radii of arterioles and capillaries offers more resistance. And the farther from the heart, the number of vessels and their total cross-sectional area become greater and greater. Arterioles are the most significant point of control over peripheral resistance and flow. They outnumber any other type of artery, providing the most numerous control points. They are more muscular in proportion to their diameter, and they are highly capable of vasomotion. Arterioles produce half of the total peripheral resistance. Vasomotion is a quick and powerful way of altering blood pressure and flow. And there are 3 ways of controlling vasomotion: local control by autoregulation, vasoactive chemicals, and angiogenesis; neural control through reflexes; and hormonal control. Autoregulation is the ability of tissues to regulate their own blood supply. The metabolic theory of autoregulation says this: if tissue is inadequately perfused, waste accumulates, stimulating vasodilation, which increases perfusion. The bloodstream delivers oxygen and removes metabolites. When wastes are removed, the vessels constrict. Vasoactive chemicals. These are substances secreted by the platelets, endothelial cells, and perivascular tissue to stimulate vasomotion. These will include histamine, bradykinin, and prostaglandins, which stimulate vasodilation. Endothelial cells secrete prostacyclin and nitric oxide, which are vasodilators. Endothelins are vasoconstrictors. Reactive hyperemia. If blood supply is cut off, then restored, the flow increases above normal. Angiogenesis is the growth of new blood vessels. It occurs in regrowth of uterine lining around coronary artery obstructions, in exercised muscle and malignant tumors, and controlled by growth factors. The vasomotor center of the medulla exerts a sympathetic control over blood vessels throughout the body. It stimulates most vessels to constrict, but dilates vessels in skeletal and cardiac muscle to meet the demands of exercise. There are 3 autonomic reflexes: the baroreflex, chemoreflexes, and the medullary ischemic reflex. The baroreflex is an automatic negative feedback response to changes in BP. It increases BP detected by those carotid sinuses. Signals are sent to the brainstem by way of the glossopharyngeal nerve. It inhibits the sympathetic, cardiac, and vasomotor neurons, reducing sympathetic tone of the vessels. It excites the vagal fibers to slow the heart rate and cardiac output, and the result is reduced blood pressure. Baroreflexes are important short-term regulators of BP, but not in cases of chronic hypertension. Adjustments for rapid changes in posture are part of this. Here's an example of a map of how the negative feedback control of that blood pressure can be regulated. If the elevated blood pressure is up, the arteries are stretched, these receptors will fire. And then we have a whole cascade of ways that we can get the blood pressure reduced. So a chemoreflex is an automatic response to changes in blood chemistry, especially pH and concentrations of O2 and CO2. Chemoreceptors are found in the aortic bodies and carotid bodies. They are located in the aortic arch and external carotid arteries. Their primary role is to adjust the respiration to change the blood pH. Their secondary role is vasomotion, stimulated by hypoxemia, hypercapnia, and acidosis. This causes widespread vasoconstriction, increasing the blood pressure, increasing lung perfusion, and gas exchange. This also stimulates respiratory rate changes. The medullary ischemic reflex, the automatic response to a drop in the perfusion of the brain. The medulla oblongata monitors its own blood supply. It activates corrective reflexes when it senses ischemia. Cardiac and vasomotor centers send sympathetic signals to heart and blood vessels. This increases the heart rate and contraction force. This causes widespread vasoconstriction. It raises BP and restores normal perfusion to the brain. Other brain centers can affect vasomotor center. Stress, angle, arousal can also increase BP. When we get into hormonal control, hormones influence blood pressure, some through their vasoactive effects and some by regulating water balance. Angiotensin II and aldosterone, they both raise BP. They are potent vasoconstrictors. They promote sodium and water retention by the kidneys. They increase blood volume. ACE, or angiotensin converting enzyme from the lungs, is required for this pathway. ACE inhibitors serve as antihypertensive drugs. In this picture, you get a good example of the renin-angiotensin-aldosterone system and how it's all linked together. So ADH raises the blood pressure. It promotes water and sodium retention because it's a vasoconstrictor. Atrial natriuretic peptide decreases BP. It increases sodium excretion and reduces blood volume. It promotes vasodilation. Epinephrine and norepinephrine, for most blood vessels, binds to the alpha adrenergic receptors, which are vasoconstrictors. In skeletal and cardiac muscle blood vessels, it binds to beta adrenergic receptors, which are vasodilators. Arterioles will shift blood flow with changing priorities. So this has to do with nervous system control, autonomic control of perfusion and where the blood flows and how it flows and how fast it flows. So in these charts, you can see the blood flow comparison, how it's divided up. During exercise, there's increased perfusion of lungs, myocardium, and skeletal muscles, and decreased perfusion of kidneys and digestion. So in capillary exchange, it's a two-way movement of fluid across capillary walls. Only through capillary walls are exchanges made between the blood and the surrounding tissues. Water, oxygen, glucose, amino acids, lipids, minerals, antibodies, hormones, wastes, carbon dioxide, and ammonia will happen at this level. Chemicals pass through the capillary wall by three routes: through the endothelial cell cytoplasm, through the intracellular clefts between the endothelial cells, and the filtration pores or fenestrations of the fenestrated capillaries. The mechanisms involved will be diffusion, transcytosis, filtration, and reabsorption. Diffusion is the most important form of capillary exchange. You have glucose and oxygen being more concentrated in blood, being more concentrated in blood, and they diffuse out of the blood. Carbon dioxide and other wastes being more concentrated in tissue fluid will diffuse into the blood. Capillary diffusion can only occur if the solute can permeate the plasma membranes of the endothelial cell, or the solute is small enough to fit between the cells, the filtration pores and the intracellular clefts. That's what they're for. So lipid-soluble substances, steroids, hormones, oxygen, carbon dioxide diffuse easily through the plasma membranes. Water-soluble substance like glucose and electrolytes must pass through filtration pores and intracellular clefts. Large particles, such as proteins, are held back. In transcytosis, the endothelial cell will pick up material on one side of the plasma membrane by endocytosis. The transport vesicle will take it across the cell and discharge the material on the other side by exocytosis. This is very important for fatty acids, albumin, and some hormones like insulin. Fluid filters out of the arterial end of the capillary and osmotically re-enters at the venous end. Delivers material to the cell and removes metabolic waste. The blood hydrostatic pressure drives fluid out of the capillary It's high on the arterial end of the capillary, where it's low on the venous end. Capillaries reabsorb about 85% of the fluid they filter, and the other 15% is absorbed by the lymphatic system and returned to the blood. The colloid osmotic pressure, or COP, draws fluid into the capillary. This results from plasma proteins, albumin, if there's more in the blood. So capillary filtration at the arterial end and capillary reabsorption at the venous end. Activity or trauma will increase the filtration pattern and system. Edema is the accumulation of excess fluid in a tissue. Fluid filters into the tissue faster than it can be absorbed. The primary causes of edema would be increased capillary filtration, which can be from kidney failure, histamine release, old age, and poor venous return. Reduced capillary absorption from hypoproteinemia, liver disease, dietary protein deficiency, or an obstructed lymphatic drainage system. Surgical removal of the lymph nodes is an example of that. Lymphedema, we call that. Effects of edema: tissue necrosis, oxygen delivery, and waste removal is repaired. Pulmonary edema, suffocation is the threat there. Cerebral edema, headaches, nausea, seizures, and coma. Severe edema or circulatory shock. Excess fluid in the tissue spaces causes low blood volume and low blood pressure. So let's talk a little bit about venous return. Venous return is the blood flow back to the heart. The blood pressure gradient is the most important force in venous return. It's 7 to 13 millimeters of mercury is the venous pressure toward the heart. The venules have to the central venous pressure is the point where the vena cava enter the heart, and this is at 5 millimeters of mercury. Gravity drains blood from the head and neck. It opposes, venous flow opposes drainage from below the heart. Skeletal muscle pump it into the limbs. Contracting muscle squeezes out of the compressed part of the vein. The thoracic or respiratory pump, this happens during inhalation. The thoracic cavity expands and thoracic pressure decreases. The abdominal pressure increases, forcing blood upward. The central venous pressure fluctuates over 2 millimeters of mercury on inhalation, 6 millimeters of mercury on exhalation. Cardiac suction of the expanding atrial space will contribute to venous return. Valves will prevent backflow. Varicose veins result in part from the failure of these valves to prevent that backflow. So here's an example of a contracted skeletal muscle, then the same muscle that's relaxed. So how the valves stay closed, and then as the skeletal muscle contracts, it gets squeezed, so that pressure towards the heart is going to open that upper valve and let the blood flow. Exercise increases venous return. The heart beats faster and harder. It increases carbon monoxide and BP. The vessels of skeletal muscles, lungs, heart, the lungs and heart dilate and increase the flow. There's an increased respiratory rate, which increases the action of the thoracic pump, and increased skeletal muscle pump. Venous pooling occurs with inactivity. The venous pressure, this happens when venous pressure is not enough to force the blood upward. With prolonged standing, carbon monoxide may be low enough to cause dizziness. This can be prevented by tensing leg muscles and to activate that skeletal muscle pump. Jet pilots actually wear pressure suits to help with this. Okay, circulatory shock. Cardiac output is insufficient to meet the body's metabolic needs. Cardiogenic shock is inadequate pumping of the heart, like in a heart attack. Low venous return is when the cardiac output is low because too little blood is returning to the heart. This can be from hypovolemic shock. This is the most common. This could be from bleeding, trauma, burns, and dehydration. Obstructed venous return shock can be from a tumor or aneurysm that compresses a vein, or from venous pooling or vascular shock, long periods of standing, sitting, or widespread vasodilation. Neurogenic shock is loss of vasomotor tone or vasodilation. This causes from emotional shock to the brainstem injury. Septic shock, bacterial toxins trigger vasodilation and increase capillary permeability. Anaphylactic shock is a severe immune reaction to an antigen, histamine released, and generalized vasodilation, which increases capillary permeability. So, responses to this shock: compensated shock. Several homeostatic mechanisms bring about a spontaneous recovery. For example, if a person faints and falls to a horizontal position, gravity restores blood flow to the brain. A decompensated shock is triggers when the compensated shock mechanism fails. Life-threatening positive feedback loops occur. The condition will get worse by causing damage to cardiac and brain tissue. Okay, so some special circulatory routes. One such route is the brain. The total blood flow to the brain fluctuates less than that of any other organ. It remains pretty constant at 700 milliliters per minute. Seconds of deprivation cause loss of consciousness. 4 to 5 minutes cause irreversible brain damage. Blood flow can be shifted from one active brain region to another. The brain regulates its own blood flow to match changes in BP and chemistry. Cerebral arteries dilate as systemic BP drops. Constricts as BP rises. The main chemical stimulus is the pH. So we understand one of our buffer systems, that bicarbonate buffer system, is going to have something to do with this. So hypercapnia is when the CO2 level increases in the brain, the pH decreases and triggers vasodilation. Hypocapnia raises the pH, which stimulates vasoconstriction. This occurs with hyperventilation, and it may lead to ischemia, dizziness, and sometimes syncope. Transient ischemic attacks, or TIAs, are brief episodes of cerebral ischemia. These are caused by spasms of diseased cerebral arteries. Dizziness, loss of vision, weakness, paralysis, headache, or aphasia can happen with this. It lasts from a moment to a few hours, often early warning of an impending stroke. A stroke, or a CVA, this is sudden death of brain tissue caused by ischemia. Atherosclerosis, thrombosis, or a ruptured aneurysm can do this. The effects range from unnoticeable to fatal. Blindness, paralysis, loss of sensation, loss of speech are common. The recovery depends on the surrounding neurons and the collateral circulation. In the lungs, low pulmonary pressure happens there, 25/10 millimeters of mercury. It flows slower, more time for gases to exchange. It's engaged in capillary fluid absorption. Colloid osmotic pressure overrides the hydrostatic pressure. This prevents fluid accumulation in the alveolar walls and lumens. And it's a unique response to hypoxia. Pulmonary arteries constrict in the diseased area. It redirects flow to a better ventilated region. So arterial pressure points, we can talk about some ways to assess that. Some major arteries close to the surface allow for palpation for pulse and serve as pressure points to reduce arterial bleeding. So hypertension It's a major cause of heart failure, stroke, and kidney failure. This damages the heart by increasing the afterload. The myocardium enlarges until it's overstretched and inefficient. The renal arterioles thicken in response to stress. There's a drop in the renal blood pressure, which leads to salt retention and worsens the overall hypertension. Primary hypertension can be caused by obesity, sedentary behavior, diet, and nicotine. Secondary hypertension, secondary to other disease processes like kidney disease and hyperthyroidism. Primary, like we said, sorry, I'm not going to read this again. Anyway, so that is the slide presentation for this lecture on blood vessels. I hope that was helpful, and we will talk to you later.